It's Dr. Honavar going first. I think you have another session, yes. So, Dr. Honavar is the mentor of most of the ocular oncologists who does a lot of ocular oncology work in India, and he has been an excellent teacher. You have already listened to him, and he is going to, take us through intraocular lesions, what is bad and what is good in that aspect. Over to you, sir, and it's an honor to have you in my instruction course.
Thank you so much for considering me. I'll be talking about, can we have the slides? It's a very simple talk on intraocular tumors. I called it 10 pearls because there's a large spectrum of intraocular tumors which sometimes are difficult to differentiate from each other. So let me start with the pearl first and then give you the cases. The first pearl is sectoral shallow anterior chamber or IRIS-M imaging is mandatory. I'm showing you a case of a young adult who presented with shallow anterior chamber, but it was sectorally shallow. You can see shallowness there, normal anterior chamber depth there. That is how it was, intermittently shallow anterior chamber with absolutely quiet AC normal intraocular pressure. So what would you suspect in this patient? Unilateral sectoral shallow anterior chamber or bumps in the iris, peripheral iris. What do you suspect? Something behind the iris, and you can't see what is behind the iris. Of course, you will dilate limbus to limbus and try to peep, slit lamp angulated in the totally opposite way, patient looking in the extreme gaze. You try to see, but many times you're not able to see. But if you're able to see, you will be able to see most likely an iris cyst because that is the most common. Especially a peripheral iris cyst or a midzonal iris cyst presents with unilateral sectoral shallow anterior chamber. Pupillary iris cyst, of course, is visible, and free-floating iris cyst is very, very, very visible. So this is what we found in this patient. You can see a nice, well-defined cyst causing humping of the iris and sectoral shallow anterior chamber. So this is very easy to diagnose, but you must do imaging. Otherwise, it's very difficult to say what a patient has. This is a midzonal cyst. This is a peripheral cyst which cannot be seen on full dilatation, whereas a midzonal cyst also presents with a hump, but you can see it on full dilatation. You can see that there are humps in the iris which are pigmented. But what you should be aware of is this situation where if not a cyst, but you find a solid lesion. And a solid lesion behind the iris is either a melanoma or a melanocytoma. So there is a diagnostic dilemma when you see a solid lesion, and it has to be further confirmed. And confirmation is by gonioscopy. Because in this patient, angle is blunted and you see tumor extending to the anterior chamber angle. If you see vascularity in the angle, then most likely it's a melanoma, and of course confirmation is by biopsy. So basically when you see a shallow anterior chamber, sectoral or unilateral in a particular claw cover with humps in the peripheral iris, the only way to diagnose one from the other is imaging, and of course few next steps. Now the second tip is that unilateral glaucoma in a young individual or a pigmented iris lesion, pupil holds the key. You should look at the pupil very carefully. This is an example of a young adult who had unilateral glaucoma where somebody had done a trabeculectomy. You can see an internal ostium there and a very funny circular PI, but you see the pupil already. See, pupil is, it's correctopia and ectropia on UVA, and behind the iris, behind the PI, you should see lens, right, or glow, but here you see something pigmented. So obviously patient has a pigmented lesion behind the iris, and he has neovascularization of the iris as well. So this was a patient with iris melanoma which was missed, and a trabeculectomy had been performed in this patient. Now you can see as a consequence of trabeculectomy, this is the scleral flap, and under the scleral flap you see the tumor, and even in the bleb you see the tumor. So this tumor which was intraocular has been made extraocular by an unintended trabeculectomy. Of course the surgeon did it in good faith, but what was necessary in this patient was imaging that could have picked up the tumor early on. But that pupil was distorted. Now you see this patient who also has a black mass in the angle, high pressure, pupil is nearly nice, round and central. There is no correctopia, there is no ectropia on UVA, there is no NVI, but a pigmented mass is present, pressures are high. So when in this situation, your first differential should be a melanocytoma. So pupil is the key. If the pupil is distorted, if there is correctopia, ectropion UVA and NVI, most likely it is a malignant tumor. If pupil is nice, round and central, no NVI, you see a black pigmented mass, most likely it's a melanocytoma. This was the mass, that was the anterior chamber angle, and that was a melanocytoma. So melanocytoma presents like this, can also present in the iris, dark pigmented mass with pigment shedding. Melanocytoma is full of pigment, it is pregnant with pigment, it sheds pigment, that settles in the anterior chamber, clogs the trabecular meshwork, and that causes elevation of intraocular pressure. That's a high magnification view. You see no blood vessel at all in it. It's relatively less vascular. Now if you have a diagnostic dilemma about a iris nevus, again look at the pupil. Here the pupil is nice, round and central. It's like a button kept on the iris. It is not distorting the iris stroma. It is silently lying there. Anterior chamber angle is all normal. This is a iris nevus. Whereas these two are melanomas. You can see pupil irregular, zip towards the lesion, and there is vessel here and distortion of the pupil. Both of these are melanomas. There is another way of looking at it, A, B, C, D, E, F. This is okay for kind of description theoretically, but most important is to pay attention to clinical signs. The next tip is that if you see a sentinel vessel, then it's a serious business. Like this patient, he may have cataract, he may have high pressure, he may have neovascular glaucoma, but unless you have done a good imaging, and what is the best imaging in such patients when you see a sentinel vessel? UBM is the best, because you tend to expect the tumor in the ciliary body, not in the choroid. Sentinel vessel is a hallmark of or a harbinger of a tumor in the ciliary body. So you dilate the pupil and you can see a tumor peeping through. This patient did have a ciliary body melanoma. So whenever you see a sentinel vessel, you should be very careful not to jump to do cataract surgery or trabeculectomy, but to do a good 360-degree UBM, concentrating in the area or the sector where the sentinel vessels are, and then make sure that there is no tumor. In this patient, on B scan also you can find a large tumor. Next tip is that if you find uveitis and hypopyon in extremes of age, in a young child, in an elderly individual, it can be sinister. Uveitis is mainly in young adults, generally. But if you find hypopyon in a young child, 5-6-year-old child or 70-year-old grandparent, you should be very careful. This was diagnosed as granulomatous uveitis. It may look like it, but there is attendant blood vessel as well. This patient actually had CA lung. This patient also has multiple nodular excrescences on the iris, but this was a variant of melanoma called tapioca melanoma. You can see on imaging that there are excrescent nodules. This patient presented with hypopyon, yellow hypopyon with multiple iris nodules. He had a colon malignancy, colonic cancer with metastasis to the iris. Now this is a 60-year-old male with left eye hypopyon. He even has a fibrin membrane on the lens. But what is striking in this hypopyon? Or what is not there that you expect in a patient with hypopyon? White eye. So white eye hypopyon is something that is to be considered very significant for masquerade. So if this patient has no posterior synechia, he has white eye hypopyon, and that was ALL, lymphoma, sorry. This is a patient again with a white eye hypopyon, and this patient hypopyon resolved for some time, and then this plastering of the endothelium, large cells on the endothelium reappeared. At that point, he had synechia as well. This patient was being treated as uveitis for a long time until these whitish material appeared in the vitreous, and finally confirmed diagnosis was ALL in this patient. So white eye hypopyon could be lymphoma, leukemia, ALL, AML, or even CML. Now, but in a young child, white eye hypopyon, this is again a white eye hypopyon, could be retinoblastoma. So it can be seeds like this which you see in the anterior chamber, or collection of hypopyon which has a level, thick hypopyon in retinoblastoma, or on gonioscopy you can see seeds in the anterior chamber angle. These are all retinoblastoma cells that have come through the zonules and got deposited in the anterior chamber. This is called depository variant of anterior chamber extension. Whereas in this patient, you can see obvious extension into the iris anterior chamber angle, and that is called infiltrative variant. There's a huge difference between depository variant and infiltrative variant because prognosis is totally different in them. If you see a heaped up hypopyon with translucent granules in the hypopyon, in a young child unilateral lesion, you suspect medulloepithelium of the ciliary body. Medulloepithelium has this balls of cells which are translucent. That's very characteristic. Again, if you find that there is what is called lens coloboma or loss of zonules, because of which the peripheral lens gets distorted and it appears as a coloboma, and retrolental vascular membrane, then that is very typical of medulloepithelium of the ciliary body. Sometimes you find it on the table. This was a pediatric. This patient has an orange lesion, quite one orange lesion you thought, but there is one more subtle orange lesion in the temporal to the macula, and he has similar orange lesions in the other eye. So multifocal orange lesions could be orange metastasis. Orange metastasis can occur classically because of which primary malignancies? Renal cell carcinoma, then plasmacytoma, carcinoid, right? And follicular carcinoma of the thyroid. So these are the causes for orange colored metastasis, and this was a plasmacytoma. Otherwise, orange colored unilateral unifocal lesions generally tend to be choroidal hemangiomas. All these were choroidal hemangiomas. I'm skipping because I don't have much time. All black is not bad, but sometimes black can be reasonably okay. This was a patient with blackish lesion, which is nothing but congenital hamartoma, combined hamartoma of the RP. This is again a black lesion, crisply defined black lesion with lucent areas. This is congenital hamartoma of retinal pigment epithelium, also called chirpy. Chirpy sometimes enlarge in size. Chirpy sometimes become from flat to placoid. That means chirpy is growing into a retinal pigment epithelial adenoma. When chirpy becomes much nodular and develops exudation, that means it is becoming retinal pigment epithelial adenocarcinoma. Earlier, chirpy was considered something that never grows, but actually chirpy can grow, chirpy can become an adenoma or even an adenocarcinoma. This was a very florid growth of chirpy into a retinal pigment epithelial adenocarcinoma. These are rare tumors but can present. Of course, that's a optic nerve head melanocytoma. If you have a pigmented retinal lesion, choroidal lesion, if there are a lot of drusen on top of it, that means that it is a chronic lesion. Any pigmented lesion with drusen or RP changes or patients who have fibrous metaplasia on top of it, it's a choroidal nevus. Whereas if you find a lot of subretinal fluid, orange pigmentation, then that is a melanoma. That's an obvious melanoma. But sometimes there are issues with diagnosing a small melanoma from a choroidal nevus. So there are rules to how to diagnose it. These are the signs that are elucidated by Shields to find a small ocular melanoma using helpful hints daily. This is a mnemonic. Thickness more than 2 millimeter, fluid meaning subretinal fluid, symptoms of loss of vision or metamorphopsia, etc. Orange pigment, which is lipofuscin, margin close to the optic nerve and fovea, ultrasound, hollowness on ultrasound, halo because of RPE changes, and absence of drusen. These are the signs which favor the presence of a melanoma. So if you're looking at it and thinking that it was a nevus, over a period of time you can actually see that it has grown. This patient has all the features that have been elucidated in this slide. So if you look at these features and if you find these features, then you should suspect that the patient actually has a choroidal melanoma. So these were the masquerades of intraocular tumors which I tried to highlight in this short talk. Thank you so much.
Thank you very much, sir, for extensively covering it. So, sir is going to go. If you have any quick question for him, please shoot. Any questions from the audience?
No.
Yeah. How many of you deal with intraocular tumors? Have you seen masquerades? Have you ever come across a uveitis patient and then finally it turned out to be a leukemia or lymphoma? No. Okay. Well, it is rare, but just keep it in your mind.